Please start, ma'am.
Right, sir. Hi, good afternoon, everyone. Today we will be discussing Block 3 of CFT, Mental Disorders, and we'll be highlighting the neurotic disorders, different personality disorders, and how do we assess those disorders. So, there's a wide range of neurotic disorders that we are going to discuss, but before we come up with the disorders, we must know what is neurosis. So, the term neurosis was coined by William Cullen. He was a physician and he described a specific group of mental disorders. And I would want to quote here that the word neurosis is derived from the Greek word. Neuron means the nerve, and with its the suffix the osis means the abnormal condition. So these neurotic disorders are a group of mental disorders and they don't have any physiological or a structural base for the symptoms to be developed. But of course, they are very much distressing to the individual, and not being able to accept those distressing thoughts or symptoms. And of course, the behavior not being so actively involved in any kind of violation, but it can be disabling to some extent. Now, neurotic disorders can be identified by a variety of symptoms. There can be obsessions, panic attacks, anxiety, compulsions, multiple body pains, excessive worries, and tiredness. Now, these disorders are not caused by organic brain disease. And therefore, as we were discussing yesterday, the schizophrenia, depression, we discussed that they depict certain symptoms like hallucinations or delusions. So, in these neurotic disorders, they do not have or they do not involve hallucinations or delusions. Wide classification of neurotic disorders, somatoform disorder, phobic anxiety disorder, other anxiety disorder, OCD, which is called as obsessive compulsive disorder, dissociative, also called as conversion disorder, and the post traumatic stress disorder. Now, if to start with, I would want to take the phobic anxiety disorders. And in phobic anxiety disorders, we will discuss agoraphobia, social and specific phobias. So, in these kind of phobias, agora, social, or specific, anxiety is evoked predominantly by certain well defined situations or the object. So, we have a stimuli, we have an object in a well defined shape, which are actually external to the individual and they are not currently dangerous. So, as a result, these situations, or you can say the objects, they are characteristically avoided so that I may not have that anxiety feeling or an impulse to break down. Now, these phobic anxieties, they can also fluctuate from mild uneasiness to a terror. And here the individual's concern may focus on certain symptoms like palpitations, feeling faint, or it can be the secondary fears of dying or losing your control on yourself or going mad. So the anxiety is not relieved by the knowledge that the other person does not regard the situation in question as dangerous or the threatening one. As I said, agoraphobia, specific or social phobia. So if we have to understand what is agoraphobia, it is basically the fear from the marketplace, the crowd. It includes various phobias embracing fears of leaving home, not able to enter the shops, the crowds, public places, or of traveling alone in trains, buses, underground, or planes. So, the lack of immediate exit is one of the key features of many agoraphobic situations. The avoidance behavior causes sometimes that the sufferer becomes completely housebound because they want to escape this current situation of getting in contact with public places or entering the shops, so they purposely try to avoid, but then they become the house arrest kind of persons. Now this agoraphobia has high comorbidity with panic disorder, right, depressive or obsessional symptoms, or also it can develop social phobias along with agoraphobia. So what happens basically, there's a situation, you have that anticipative anxiety. Oh, what if I get into that shop or in a public place or in a crowd? And then that turns into your phobic anxiety, that you have that forever. There's no real fear, but then phobia is like there's no real danger, but that has converted into a phobia, that you purposely avoid all such situations, the imaginary fears, getting in contact with the crowd or the public shops. Now, if I talk about social phobias, this is a fear of being scrutinized by other persons in comparatively small groups. So, what we will do? We will again tend to avoid the social situations. Like, for example, you will restrict yourself to eat in public, or you yourself to be introduced to other people, or even public speaking, or you have some kind of an encounter with the opposite sex. So basically, the social situations outside the family circle, right? Even at times, they are being diffused and kept into this, or be called as social phobia. So, persons suffering with social phobia, they find the situations stressful where they have to make eye to eye confrontation, direct eye to eye confrontation. And then, of course, the symptoms they can progress to panic attacks. And then you prefer complete isolation over getting in touch with the small groups or being introducing yourself, or a kind of interaction with the public front, at a public front. So you prefer being isolated. Now this social phobia, it usually starts in childhood or adolescence, and it's equally common in both the sexes. Then specific phobias, that's the isolated phobias. Now the specific phobias can be for spiders, for insects, for snakes, for heights called as acrophobia, for thunder, for darkness, for closed places, that's called as claustrophobia, CLAUSTRO, claustrophobia, and then also fear of diseases, injuries or some kind of medical examinations, like हम में से कुछ लोग डेंटिस्ट के पास विजिट करने से डरते हैं, or even the sight of a blood, that's called as hemophobia. Then the fear of being exposed to venereal diseases, for example, AIDS. Now, usually it arises in childhood or early adult life, and it can persist for decades if they remain untreated. If they are not treated, they can be persisted for decades. Now, we have other anxiety disorders also, like generalized anxiety disorder called as GAD, then mild or mixed anxiety and depressive disorder. So, these are the codes given in the DSM, Diagnostic Statistical Manual. Now, panic disorder. Now, all of these disorders, they come under the category of neurotic disorders only. So, in panic disorder, the essential features are recurrent attacks of severe anxiety, which are not restricted to any particular situation or set of circumstances. So, what can be the typical symptoms of panic disorder? Chest pain, choking sensation, dizziness, palpitations again, and these attacks usually last for minutes. Now, frequent and predictable panic attacks, they produce fear of being alone or going into the public places. The afflicted persons, they used to think that they got a serious somatic disease. And the cause of panic disorder is long lasting and of course complicated. Now, general anxiety disorder. Now, the essential feature in GAD is that anxiety is lasting more than 6 months, quite a big time, which is generalized and persistent but not restricted to or even strongly predominating in any particular environment circumstances. Now, generalized anxiety disorder, there is a worry kind of a thing all of the time. You are asking the person that what happened? Is there any real cause? Is there any source of like any reason, any stress? So the person says, no, but I don't know. I don't have exactly the reason, but I feel worried. So you have continuous feelings of nervousness. To a certain extent, there can be dizziness, sweating, then trembling, and then even muscular tension. Now, fear that the patient or a relative will shortly become ill or have an accident, they are often expressed together with a variety of other fears and forebodings, which are a part of general anxiety disorder. Now, its course, the duration is usually fluctuating and it becomes chronic. You know why? When it is connected with symptoms of frustration, then sadness, and even complicated when substance use disorders are associated or some way or the other they are connected to this generalized anxiety disorder. Now, what are the causes of anxiety disorders? So, there's a well known etiology developed from genetic factors. They say that genetic factors play a very important role. Few things they travel within the hereditary. And the monozygotic twins, if I talk about them, the monozygotic twins have higher chance of getting these disorders than the dizygotic twins. And then the biological parents, they are on high risk of sharing the genes with their children. So near the relative, the closer the association with the relative, the chances are like he or she can get the same disorder. Now, certain non-genetic factors such as stressful life events, even they are important and they can also play a important role. Then apart from psychological factors, there are certain biochemical factors, right? Like neurotransmitters. And particularly with anxiety disorder, we have a neurotransmitter associated called as GABA, GABA. That's also called as gamma aminobutyric acid. And then certain level of serotonin, another neurotransmitter, is also responsible. Maybe the excessive secretion or the um, inhibitory response of these neurotransmitters can be held responsible for the cause of anxiety disorders. Now, how do we manage these anxiety disorders, which means the treatment? So, various psychotherapeutic techniques are involved, and the foremost is the cognitive behavior therapy, right? Then psychodynamic approaches, systematic desensitization, avoidance, flooding, muscular relaxation techniques, then then psychopharmacotherapy. So this is in connection with the medicines. And there are different medicines like benzodiazepine, right? Some anxiety blocking drugs are being given, and then even various types of antidepressants. Now, further, I'm going to discuss the OCD, obsessive compulsive disorder. Now, what are obsessions? They are the thoughts. Compulsive, these are called as actions. So, obsessions are the thoughts, the ideas, the images, or the impulses. Now, they enter into the individual's mind again and again in a stereotyped form. For example, आपने सुबह कोई song सुन लिया, time and again that the same song is coming to your mind. I mean, that this is on the lighter form, but then certain ideas and images which can be dangerous for your own self and for the other person, they are time and again coming into your mind. And now these thoughts or the images or the ideas that I'm talking about, they are recognized as the individual's own thoughts, even though they are involuntary or even repugnant. So now the common obsessions nowadays, I think we are like everybody is high on washing your hands, but you know what? At some point, it was considered as an abnormality when you are washing your hands like some 50 to 60 times in a day. So the common obsessions include fears of contamination or harming other persons or sinning against the God. So if you have that fear of contamination, time and again you're going to wash your hands. But now this is the need of an hour, that the things that we are doing, washing your hands, wearing mask and wearing gloves. Now what are compulsions? These are repetitive, purposeful and intentional behavior. See, obsessions were related to your ideas or your thoughts. Compulsions are your actions. So certain mental acts performed in response to the obsessions. And why do we perform them? What is the need? That it is given a shape of behavior or an action? Because they tend to or they help to reduce the discomfort that otherwise is creating a dreadful situation in their own self. So they want to get rid of that anxiety or discomfort. So they put their thoughts into the action. And I want to tell you that OCD is frequently overlapped with depression and also suicidal thoughts. Now, what are the causes? Now, they say that it occurs more often in persons who have various neurological disorders, right? Including cases of epilepsy, head trauma, Huntington's chorea, certain congenital abnormalities, birth injury, growth delays, and so on. Then the excessive or the deficit secretion of neurotransmitter, serotonin, right? And then certain neuroimaging techniques, the scans have revealed, they have provided us with some evidence that basal ganglia, that is considered as the seat of emotions in the brain, basal ganglia, BASAL, ganglia, GANGLIA. So even that is held as responsible or playing a vital role in the involvement for the persons with OCD. So maybe some kind of injury or a lesion to this particular part of your brain can result into OCD. So even for the treatment of OCD, we need to rely on some medicines, some antidepressants. Then if we talk in terms of therapy, then CBT because we need to work on the person's thoughts, and then their compulsions, the behavior, then the family therapy because we need the support from the family. We need to make the family understand that what the patient or a client is going through and what kind of support they can provide. Certain patient support groups. So when a patient realizes that I'm not the alone person or I'm not the only one, right? And maybe the milder symptoms the patient have, and he can see a person getting worse on those symptoms. So maybe some kind of uh, belongingness or maybe some motivation to come out of the situation can provide a support to a person. And also the psychosurgery can help the person to curb these kind of mental illnesses. Now, the dissociative disorders. They're also called as conversion disorder. So dissociative, see, something that you have in your in a psychological at a psychological level, but not on a physiological ground. It can be amnesia. If you remember, I think in our first lecture, when we were discussing the cognitive disorders, maybe yesterday or day before yesterday, we discussed delirium, dementia, amnesia, or amnestic disorders. So the dissociative disorders are the conversion disorders. They have convulsions, sensory loss. They can run, patients can run, but they cannot walk. So one or the other traumatic event has led them to behave like this or have landed them to this current position. Now, the common theme that is being shared by dissociative disorders is a partial or a complete loss of normal integration between the memories of the past. The person is not able to recall the previous activities held in his life, even the identity, then the immediate sensations, and also the control of bodily movements is lost. So it can be partial and it can be complete also. But I also want to tell you that it doesn't mean that they are not conscious anymore. So a considerable amount of conscious control over their memories or sensations is still there. And certain kind of movements can also be carried out. Just like I said, that the person cannot walk, he says, but he can run. He cannot talk, but he can sing a song. So the prevalence is actually not known, but of course up to 10% of cases we have seen. And they say there is a sudden onset and then the termination of such kind of states. एकदम से होता है and then कुछ maybe like 3 months, 6 months and then ये subside भी अपने आप कर जाता है. Now there are several forms of dissociative syndromes, dissociative amnesia. And what is the main feature of this? The loss of memory. And that is also of important recent event. And now this kind of amnesia, dissociative amnesia, is not due to any organic mental disorder. The amnesia is, as I said, usually centered around traumatic events like accidents, certain stressful or combat experiences, or even unexpected death of a loved one, bereavements, and of course this amnesia can be partial or complete. And then this kind of amnesia, it typically develops suddenly and then lasts from minutes to certain number of days. Then another kind of dissociative syndrome is dissociative stupor. Stupor, S-T-U-P-O-R, dissociative stupor. Now the individual suffers from, you can see, the absence of the voluntary movement. and the normal responsiveness to external stimuli like light, noise, and even touch. So, what happens? The person lies or he sits largely motionless for a long periods of time. Stupor एक particularly statue stage हम बोल सकते हैं. स्पीच हो गया या आपका कोई पर्पसफुल मूवमेंट है वो कंप्लीटली एब्सेंट हो जाता है इस स्टूपर स्टेज में. Then your muscle tone, your posture, your breathing, even your coordination of your eye movements. It is clear that the individual is neither asleep not nor unconscious, but थोड़ा still form में नजर आता है. Then we have dissociative disorders of movement and sensation also, and they are categorized as dissociative motor disorders, dissociative convulsions. So these are the disorders of movement and sensation. Dissociative anesthesia, and there's a syndrome called as Ganser's syndrome. GANSER''S. Ganser's syndrome. It's like an approximate or grossly incorrect answers the person is giving. And then, of course, the multiple personality disorder. So, multiple personality disorder, a lot of movies have been filmed over this particular disorder. The presence of two or more distinct personalities with an individual, right, with only one of them being evident at a time. And what happens when one becomes the host and another subsides, and according to situation, the person keeps on swapping those multiple roles. And ये दो नहीं, दो से ज़्यादा भी हो सकती है. Now, for these kind of disorders, the dissociative or the conversion disorders, I think the best therapy is the psychotherapy, psychodynamic programs, or even the hypnosis. Now, certain stress and adjustment disorders, and in DSM, they are called as reaction to severe stress and adjustment disorders. Now, this category differs from others जो अभी तक हम पढ़ते आ रहे हैं. Here, what can be the cause? Exceptionally stressful life event. It can be a natural or a man-made disaster, combat, an accident, witnessing the violent death, or being the victim of the torture, terrorism, or some other heinous crime. And now these kind of causes bring significant life changes in the person's life. And then this leads to the continuous unpleasant circumstance and then results into an adjustment disorder. Person has difficulty adjusting to such traumatic, unexpected changes. So in adjustment or stress disorders, the stressful event is thought to be the primary and the overriding causal factor actually. Now the acute stress reaction. For example, an initial state of days with some constriction, some gap to your conscientiousness, narrowing your attention, you're not able to comprehend the stimuli. That's acute stress reaction. And then disorientation. Further, आपका withdrawal हो सकता है from the surrounding situation. आप stuporous stage में statue form में जा सकते हैं या आपकी hyper psychomotor activity हो सकती है. There are certain autonomic signs in acute stress reaction. For example, sweating or flushing. And these symptoms, they usually appear within minutes of the impact of the stressful event, and then they disappear within several hours, like 2 to 3 hours. Now, PTSD, post-traumatic stress disorder. Now, this is a delayed or a protracted response to a stressful event. The event has already occurred. Exceptionally threatening, or the event is of catastrophic nature. So, this post traumatic stress disorder has three major elements. One can be you are re experiencing the same trauma through your dreams, जिसको हम flashbacks भी बोलते हैं. Second is you are showing emotional numbing, such as feeling detached from others. You are detached, but you're still connected that way. Then having symptoms of autonomic hyperarousal, such as irritability, you know, insomnia. So there's a fear, and then you also want to avoid the situation at the same time. And with this PTSD especially, there is high comorbidity seen of anxiety and depression. So there's a trauma, you have the acute reaction to that trauma, and then you are re-experiencing those traumas in the form of flashbacks. Now, how do we handle these disorders? We prefer to give patients antidepressants, right? Mood stabilizers, antipsychotic drugs. Then psychotherapy is also of great importance. Cognitive behavior therapy, group therapy, family therapy, and then various self-help groups are also recommended. Adjustment disorder. Now, this comprises states of subjective distress and the emotional disturbance. Why? They are arising in the period of adaptation, actually. When a person is trying to adapt to a significant life change or to the consequences of a stressful life event, right? For example, a severe physical illness you can take, or maybe some kind of separation or migration. So you're just trying to adapt yourself to the new situation. So the person can have depressed mood, anxiety, worry, a feeling of inability to cope or plan ahead. And then the onset of these kind of disorders is within a month, and maybe like for 6 months or below 6 months, it keeps on going. So here also, psychotherapy is the first line treatment for this kind of a disorder. Now the another category of disorders, somatoform disorders. Somatization disorder, undifferentiated somatoform, hypochondriacal, hypochondrosis पे एक movie भी थी, PICU, somatoform autonomic dysfunction, persistent somatoform pain disorder. So all these disorders or the categories, they are given in DSM. Now the somatoform disorders, the multiple, recurrent and frequent somatic complaints in which you require medical attention without any association with any physical disorder. You don't have that physical disorder, but you are continuously complaining. Now, the medical history of multiple contacts with the primary care or the specialized health services is typical before the patient is referred to this psychiatric care. तो क्या characteristics क्या है ऐसे लोगों के? They have the complaints of being associated with the severe organ disorder, right? They try to exacerbate or maybe exaggerate the things like psychological problems they have, the conflicts that are important in initiating, exacerbating, and maintaining the disturbance. So, such kind of disorders, they are there, the presence of these the symptoms are there for 2 years of multiple and variable physical symptoms. But mind it, there's no physical explanation for all these physical symptoms actually. And then they refuse to accept, the patients refuse to accept the advice or certain kind of reassurance of several doctors that there's no problem with you. or there is no physical explanation for the symptoms even. Some degree of impairment of social and family functioning can also be attributed for the development of such kind of disorders. Now, I will discuss few personality disorders. So before we switch on to personality disorder, right? World Health Organization defined abnormal personality as deeply ingrained maladaptive pattern of behavior, which is continuing throughout your adult life and although often becoming less obvious in the middle or the old age. So the maladaptive behaviors that you have acquired, they can result in loneliness, suspiciousness, and even you can withdraw yourself from the reality. So the personality disorders, they fall somewhere within the maladaptive range. And then the degree of that maladaptiveness depends on the type of disorder or even the symptoms you have. See, these personality disorders, now these are not the mental illnesses. So it's not a mental illness, it is a maladaptive behavior. Of course, it's long lasting, and of course, DSM says that it causes significant impairment in your social life or in your occupation. And at the same time, it also produces distress. So, personality disorder is different from mental illness, right? The symptoms of personality disorders, they are continuous and they start from the adolescence or even before. Now, we can call these patients, I mean, the patients suffering with the personality disorders as odd, but not mad. They can be peculiar. Some peculiarities can be there, but they are not mad or insane. Now, what are the factors associated or responsible for such kind of a disorder? Biological factors. So, when I say biological factors, the role of hereditary, biochemical factors, low level of serotonin is held responsible for developing personality disorders. Then certain family history, like alcoholism or any other psychiatric problem. Factors related to your development, like early traumatic experiences. And maybe you have some kind of a loss that you have suffered by your attachment figure, can be mother, father, your sister, brother, whosoever you are attached to. Then even childhood abuse, sexual abuse, or lack of parental care. These development factors can play a sufficient role in developing these personality disorders. The socio-cultural factors, see isolation, and then the long-term psychiatric problems, immigration, of course, diaspora, lack of close family ties which promote loneliness. There's a sense of actually emotional loneliness, right? फिजिकल लोनलीनेस का तो फिर भी कहीं ना कहीं कोई सॉल्यूशन निकल आता है, बट इमोशनल लोनलीनेस जो है वो ज्यादा एक ट्रिगरिंग फैक्टर होता है. देन सर्टेन साइकोलॉजिकल फैक्टर्स, separation of parents, and that's the effect of that on children. You have um, you don't have coping strategies, your dependency, anxiety. So now, how do we classify personality disorders? DSM-4 has classified the personality disorders into three clusters: cluster A, cluster B, cluster C. So cluster A is for odd and eccentric personality. Cluster B is for dramatic and emotional personality. And cluster C is for anxious and fearful personalities. So in cluster A, we have paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B, that we were saying dramatic, emotional. So we have antisocial personality disorder, histrionic personality disorder, self love, narcissistic personality disorder, and the borderline personality disorder. Now, the anxious and the fearful personalities, that is cluster C, we have avoidant personality disorder, dependent personality disorder, obsessive compulsive personality disorder. So, quickly, I will go through certain features of different personality disorders, like that those who fall under cluster A, B, and C. So, paranoid, see, this disorder is more prevalent in males than females. So, this is the research which is saying. So, this is marked by complete distrust of other people, some kind of suspiciousness, right? They search for hidden meanings. They have hostile intention in everything others say or do. So they believe that somebody wants to kill them, someone is following them, या उनको कोई poison करना चाहता है. What are the symptoms? They are suspicious, they are argumentative, they are stubborn, hypersensitive, and irritable. Schizoid personality disorder. So the important characteristic is social withdrawal. They are commonly known by, or they're commonly known as loners, Loners, right? No close friends. They maintain a social distance. Now we all need to maintain that, in fact. But this, when it becomes a kind of a disorder, even from family members actually, and seem unconcerned about others. So they are emotionally cold, uh, too much introspective, and they don't have any desire or wish to enjoy their intimate or close relationships. Schizotypal, they have a certain kind of odd thinking, acute discomfort, they are odd beliefs, या magical thinking होना, right? Social withdrawal, I mean eccentric, social isolation, not fitting easily with others, and certain kind of inappropriate affect. मूड जो है वो बहुत ही ज़्यादा डिस्टर्ब सा है उन लोगों का. नाउ क्लस्टर बी, एंटी सोशल, एडोलेसेंस में ये देखा जाता है. So when you are violating the rights or the social norms and then predisposing the person to criminal tendencies, for example vandalism, right? The person whosoever is not able to maintain the consistent responsible functioning, can be at work, at your workplace, your school, or even as a parent. So you have impulsive actions, you have low tolerance to frustration, lack of guilt, and then again, you're not able to handle your interpersonal relationships. Histrionic personality disorder. Histrionics, नाम से ही थोड़ा सा हमें क्लियर हो रहा है. So the attention seeking behaviors for momentary excitement and fleeting adventure. So now this disorder is most common in females. The research says like this. Or maybe the cases they have turned around. They have been able to find maximum cases of these kind of personalities in women. So they're dramatically emotional, right? Emotional blackmailing, um, maybe demonstrative suicide attempts, attention seeking behavior, lack of consideration for others, and etc. Narcissistic personality disorder. Now, patients with narcissistic personality disorder, they're self-centered, self-absorbed, and they lack some kind of empathy. Borderline, Borderline personality disorder is actually marked by a pattern of instability in their interpersonal relationship. They have deviated mood, behavior, self image, unstable relationship, बहुत ज़्यादा impulsive होने, unstable self image होना. They're not able to control their anger, and they are repeatedly giving suicidal threats to others. Even they are uncertain about their personal identity. Now, the last category, cluster C, avoidant personality. Now, people with avoidant personality, they have low self-esteem. They don't have confidence. So most of the time, you are going to view them as having a negative self-concept developed. They are shy, they are insecure, and they have a lot of fear of being rejected. Dependent, dependent personality disorder. So they have that extreme need actually to be taken care of. And then they become submissive, and they also fear of being separated or being rejected. They need constant reassurance and support from others. Obsessive compulsive personality disorder. Initially, we discussed this in anxiety disorder. Here, we are discussing this in personality disorder. So, in this disorder, the individual places a great deal of pressure on himself and other not to make a mistake. So, believes his way of doing something is the only correct way. सो बिकॉज ऑफ दिस ऐसा हो सकता है कि जो पर्सन है वो अपने आप को अब खुद को या दूसरों को राइट मॉरल प्रिंसिपल्स पे फॉलो करने को बोले. सो काइंड ऑफ परफेक्शनिस्ट, हाई स्टैंडर्ड्स, एक्सेसिव डाउट अपने आप में फील करना, ये लोग ऑब्सेसिव कंपल्सिव पर्सनालिटी डिसऑर्डर में आते हैं. अब इन डिसऑर्डर्स को ट्रीट करने के लिए वी कैन गिव द साइकोडायनेमिक ट्रीटमेंट्स, working, focusing on their unconscious processes, providing them with some kind of insight, and then they can work on their problematic behaviors. So, what is the goal of psychodynamic therapy? See, the concern is that client self awareness or the understanding of the influence of the past on present behavior is important. How those childhood experiences or past experiences are affecting your today's time. Then CBT, working on your thoughts, feeling, and then bringing down it into your action. Now, apart from understanding the disorders, once you know the so and so person is suffering from this particular disorder, how do we assess them? So, personality disorders means the use of clinical tools. But of course, we can make use of certain subjective methods also. We make use of objective test, certain subjective test, and projective techniques to assess, basically to screen out the personality disorders or different personalities, deviated personalities. So if I begin with, we have self report inventories, इनको हम पेपर पेंसिल टेस्ट भी बोलते हैं. बट इसकी लिमिटेशन यही है कि इसमें जो पर्सन है वो सिर्फ यस या नो में जवाब दे सकता है, अपनी सब्जेक्टिव फीलिंग्स को वो एक्सप्लोर नहीं कर सकता है. Then we also have multi-dimensional test. Then very common 16 personality factor questionnaire to identify different traits. But if I talk in terms of the clinical tools, purposely clinical tool, so the current tool being used as a diagnostic module is MMPI-2. Initially, there was a version called MMPI-1 or MMPI. Now it's been revised, so it is called MMPI-2. So this inventory, Minnesota, MINNESOTA, Minnesota Multiphasic Personality Inventory, It consists of 567 statements. Like, for example, uh, I'm very often tense. Now, the person taking the test, he must answer as true, false, or cannot say. Now, this inventory has 10 clinical scales. So, 10 clinical scales include those different syndromes that we have read. So, they are being included in this test, in this inventory. And then there are 8 validity scales. Now, these validity scales will help us to identify whether the person suffering with so and so disorder is actually faking or is seriously on real grounds going through certain problem. So that's the use of the validity scales, because we fear that maybe the person gives the socially desirable answers because there's a lot of stigmatization that I might be diagnosed with a disorder and then people will judge me with that only. We also have certain projective techniques to understand the feelings, the subjective feelings of the person. So these projective techniques, they are basically designed to assess the to help the clinical psychologist in understanding or diagnosing the nature and the severity of the person's emotional disturbance. So in projective techniques, we have thematic perception test, जिसमें आपको एक पिक्चर दिखाया जाएगा. There are 31 cards. उनमें से उन हर कार्ड पे एक एक पिक्चर बना होता है. A story is being depicted and the person is asked to write a story on that particular picture in that card. And then the story, I mean, whatsoever is being written, is being interpreted as the person's own feelings. Then, sentence completion test. There are certain behavioral assessments, observation techniques, and situational test, which we try to use and find out the disturbed emotions that a person is going through and can help the person to get the treatment or some kind of therapy in a better manner. Sometimes, these situational tests, they are also called as behavioral tests because they are directly concerned with the observable behavior. For example, self-control and maybe the cooperation the person is depicting. So that's it for today. I have tried my level best to complete the different disorders. I know there are a lot many disorders, but my concern was to focus on the important ones. Others are also equally important, but just to make you or to get an awareness that what are the different kind of neurotic disorders, personality disorders, and what are the ways, how do we assess those personality disorders. So from a psychologist's point of view, we focus on using the diagnostic tools before we um, give a diagnosis of any particular personality disorder. So that's it for today. Thank you so much.
हेलो हेलो
हेलो.
जी मैम
हाँ जी सर.
विद्यार्थी कुछ पूछना चाहता है तो पूछ सकता है हमसे
Ma'am,
सर
thank
हम
you so much.
क्वेरीज
It
कल.
was, sorry.
ओके. हाँ जी. यस यस प्लीज.
Yeah, I was just saying thank you so much. It's been very informative and very detailed.
थैंक यू
Appreciate it.
सो
Thank you
मच.
so much.
थैंक यू सो मच डियर. थैंक यू.
सभी लर्नर्स अपनी अटेंडेंस जरूर लगाएं चैट बॉक्स में